Welcome to this short video on psychosocial factors in early pregnancy. Hi, and welcome to this short video on psychosocial factors in pregnancy. And we're going to focus particularly on early pregnancy as a time for support and early intervention. So what do we mean by early pregnancy? Well, early pregnancy refers to the first period of gestation, lasting 12 weeks. It's also known as the first trimester, and it's a period marked by rapid fetal development and significant hormonal changes in the body. And it's a key time period for health, although the midwife has limited contact with women in this time period, and that is something that various health reports are always looking to increase amid the constraints of the NHS system. And what do we mean by psychosocial factors? Well, psychosocial factors are the interplay of psychological and social influences that impact a person's thoughts, emotions, behaviours and overall well-being. It includes aspects such as mental health, relationships, cultural expectations, socio-economic circumstances and life experience. And we want to think about healthy lifestyles when we're thinking about psychosocial factors in early pregnancy. And these are patterns of self-initiated behaviours and perceptions that serve to maintain or enhance the level of individual well-being. And these behaviours generally consist of 6 domains, so nutrition, physical activity, health responsibility, stress management, interpersonal relationships and self-actualisation. Pregnancy represents a profound period of physical, emotional and psychological transformation for the pregnant woman or person. The hormonal changes, particularly the rise in estrogen and progesterone, which are very high in early pregnancy, can lead to a significant mood fluctuation. It's really common for individuals to experience uncertainty, emotional highs and lows, and mixed feelings about pregnancy, as well as concerns about birth and parenting. These emotional shifts might be compounded by stress related to identity, their relationship and their future expectations. Research indicates that up to 1 in 4 pregnant individuals experience symptoms of anxiety, and depression is also prevalent during this time. The transition to parenthood also affects fathers and co-parents, although research in this area, especially for LGBTQIA families, is limited. Many fathers express a need for more guidance and support in preparing for parenthood during this time. A shift in identity is really common for new and expectant parents. Pregnant individuals may feel that others perceive them differently, and their own sense of self may evolve in response to changes in body image, workplace dynamics, and interactions with healthcare professionals. For many women, this will be the first time that they are really encountering the healthcare system and perhaps being transformed into a patient. And these changes can evoke feelings of real uncertainty. And pregnancy, importantly, can also bring challenges in relationships. So emotional changes, altered communication patterns, a change in couple dynamic can lead to arguments, and these shifts can contribute to stress. And evidence shows that approximately 30% of domestic abuse begins in pregnancy, highlighting the need for support from healthcare professionals to identify that when it is occurring. Early pregnancy presents a critical window for engagement with maternity services. Unplanned pregnancies often complicate this process due to emotional, societal and cultural factors. Women might experience significant stigma, particularly depending if they come from a community where premarital or adolescent pregnancy is taboo, which can lead to delayed access to antenatal care and poorer outcomes. Cultural beliefs can also significantly shape perceptions of pregnancy and influencing when women choose to seek care and if they choose to adhere to medical advice. For example, language barriers or traditional practices and fear of judgment may reduce people's engagement with services. Trauma-informed care is essential in supporting women with complex social backgrounds, including those who have experienced pregnancy loss, domestic abuse or systemic discrimination. And NHS England recommends that all maternity staff adopt trauma-informed principles, ensuring care is compassionate, person-centred and sensitive to psychological distress. A concern is access to maternity care in this period. Women facing social risk factors such as poverty, they may be asylum seekers, they might be substance users or suffering domestic abuse, are disproportionately affected by poor maternity outcomes, including stillbirth, neonatal death and maternal mortality and morbidity. These outcomes are closely linked to the systemic barriers that hinder access and engagement with services, therefore reinforcing their existing health inequalities. Barriers to care often include a lack of documentation, unfamiliarity with the NHS system, and the fear of disclosing complex personal circumstances. These challenges can delay or prevent timely access to antenatal services, and as discussed, language barriers further compound these issues, with the absence of interpreting services posing a real risk to safety and communication. Some women also may perceive maternity services as judgmental or punitive, particularly when safeguarding concerns are involved. So transparent safeguarding procedures and respectful, non-stigmatising care can really help to mitigate these perceptions and foster trust between individuals and healthcare providers. Avoiding a paternalistic attitude and systemic discrimination, because these can undermine women's sense of eligibility or candidacy for care and discourage them for seeking support. As a midwife and student midwife, it's important that you're aware of the circumstances that may limit women's access to maternity care and impact their health outcome. Women from marginalised groups, such as those from Black and minority ethnic backgrounds, those who experience poverty, those experiencing young motherhood, homelessness, language barriers, all that you can see on the screen here, are an increased risk of poor maternity outcomes. Tackling these inequalities begins with recognising how maternity care might unintentionally disadvantage these groups based on their ethnicity, socioeconomic status, or pre-existing health and social conditions. Systemic issues can also worsen these disparities. For example, charging undocumented migrants for maternity care can deter early engagement, and a standardised approach to care that fails to account for these individual needs may contribute to excluding the most vulnerable, contributing to structural racism. Additionally, cultural barriers and a lack of training and cultural sensitivity amongst healthcare professionals can limit the effectiveness and inclusivity of care. Women in England's most deprived areas are more than twice as likely to die during pregnancy or experience adverse outcomes like stillbirth, preterm birth, and fetal growth restriction compared to those in affluent areas. The lack of clarity around the mechanisms influencing outcomes does make it difficult to design effective services to improve these. So it's important that within healthcare services, different care models are continually evaluated to identify what works for this at-risk population. Intersectionality is an important concept, and what this means, or it's a metaphor for understanding the ways that multiple forms of inequality or disadvantage sometimes compound themselves and create obstacles that are not often understood among conventional ways of thinking. For example, a person may experience several forms of discrimination, such as sexism, racism, and ableism, all at the same time. For example, a Roma woman might experience discrimination in pregnancy based on both her gender and her ethnicity. Intersectionality is important for gender equality, particularly because it helps us understand how different forms of discrimination interact and exacerbate inequality. If we fail to consider intersectionality, our efforts to promote equality might be limited in their impact or could even worsen the situation for some of the most disadvantaged women. For example, a project aimed at empowering women might overlook the specific needs and difficulties faced by Black women, potentially worsening their marginalisation. And early pregnancy presents an opportunity, and it's a real opportunity for health promotion. Screening for domestic abuse, mental health and safeguarding concerns can be done early in pregnancy and should in fact be done throughout the pregnancy. We can give advice on nutrition and physical activity to improve people's overall health. Advice about smoking and alcohol cessation support services make a real tangible impact on people's lives and the health of their unborn fetus. And we can, of course, offer many forms of health screening to allow women to make informed choices. However, it is important because to get these opportunities, women do have to have access to healthcare. So we need to consider inequalities and structural inequalities when we are trying to improve health outcomes in early pregnancy. So the key messages: women face a range of changes and challenges in the first trimester, and support an early intervention as well as understanding of the complex circumstances and the intersectionality aspect is key to improve health outcomes.